to use that platform to just really ask the question about how responsive nursing education is in South Africa and in the future beyond, particularly responsive to our rural communities. Another thing is also, we are to look at this question in light of communicable and the non-communicable diseases that we are facing today. The big one that we are all just so mostly likely aware of is the coronavirus pandemic that we are facing, as well as other social issues in South Africa, such as the gender-based violence, which many argue that it on its own is a pandemic by its own right, as well as racism. So I'd really just like to welcome you all to this wonderful webinar, and I hope we all enjoy it and we gain wonderful insights from it. Moving along is just to introduce our speaker, Professor Laetitia Rispel, who will be delivering a keynote address for us this very afternoon. So Professor Laetitia Rispel is a qualified professional nurse, midwife, a pediatric nurse. She holds a South African research chair on the health workforce and is a professor of public health at the University of the Witwatersrand in Johannesburg. She is a former head of Wit School of Public Health and a former head of the Gauteng Department of Health until 2006. Professor Rispel has extensive and wide-ranging experience of research, teaching, health leadership in different settings, and has published extensively on different aspects of health policy, as well as the transformation of the South African healthcare system. She has won several national and international awards. On June 9th, 2020, she completed her term as president of the World Health Federation of Public Health Association, the first woman from Africa and the third in the 55 years history of the organization to achieve this honor. So it is also my honor to welcome Professor Laetitia Rispel this afternoon. Thank you.
Thank you very much, Lungi. Is it over to me?
Yes, please, ma'am.
Okay. Good afternoon, colleagues, and good afternoon to Ms. Lungile Gamedi and Mr. Russell Rensburg from the Rural Health Advocacy Project. I would also like to greet all the attendees who are with us. I see there are 39 people in addition to the panelists. It's a very weird feeling to be sitting at home and to be doing a keynote address. Initially, we envisaged that this would be a face-to-face dialogue, but I want to congratulate Lungi for pursuing with the idea and for making sure that this happens. The theme of the webinar of the RHAP is entitled The Future of Nursing in South Africa, Challenges, Opportunities and Social Accountability in Nursing Education. I've already thanked Lungile, but I also want to congratulate her for organizing this webinar with a very brave theme, because it's hard to talk about the future at such a difficult time in history. I want to also thank you for the honor to present the keynote address at this webinar, which comes at an unprecedented time in history. At 8 o'clock this morning, around 8.3 million COVID-19 cases and 446,000 deaths have been reported globally. In South Africa, 76,334 and 1,625 deaths have been reported. There appears to be no end in sight And in almost all countries of the world, the COVID-19 pandemic has caused unbelievable hardship, suffering, and devastation, laying bare the pre-existing injustices and inequities, whether by geography, by race or ethnicity, or other forms of vulnerability, with poor people and poor nations bearing the brunt of these inequities. At the same time, with the COVID-19 pandemic, we are also witnessing another silent pandemic, one that has been with us for a long time and that no one talks much about, that of structural and systemic racism and racial injustice. The senseless and brutal killing of George Floyd at the hands of the security forces in the United States of America has been the proverbial straw that broke the camel's back. Endemic and structural racism throughout the world is part of a deeper public health and human rights crisis that disproportionately affects people of color, a term that I dislike, but I'm using it for lack of a better word. It's a pandemic that consists of structures, of systems, and policies that create social and economic conditions that lead to health inequities, differential rates of death and disease, dehumanization of people, and violation of their human rights. In South Africa, the Nelson Mandela Foundation has reminded us that the 26 years of democracy have not yet ensured that Black lives matter as much as white lives. The foundation highlighted the ongoing structural violence against Black lives constituted by patterns of poverty and inequality deeply rooted in our histories of colonialism and apartheid. Superimposed on the poverty and inequalities is the endemic gender-based violence that goes to the core of our humanity. Lukhele has already reminded us about it, but in the past 2 weeks, 14 women and children have died in yet another cycle of gender-based violence, the brutal nature of which makes us feel sick to the core. We express our outrage and we protest, but little seems to change between Uyenene's brutal murder in August last year and Sekhofatso more recently, except that the brutality of the murders is more in our faces. I urge all of us to reflect on what we can do, both individually but also collectively, to ensure that women and children are safe and that they stay alive. Colleagues, it's very easy to become despondent and ruminate only about the problems and obstacles. And of course, we have to be aware of reality in order to develop solutions to these problems. But as the Nigerian novelist Chimamanda Adichie reminds us, there is the danger of a single story or a single narrative. She says that there's nothing wrong with a single story, but the problem arises when the single story becomes the only story. So Lukhele and RHAP organized the seminar also to celebrate the contribution of nurses in light of the International Year of the Nurse and Midwife, and to start a discourse on the importance of investing in nurses and nursing. Let me start by saying that there isn't a single story or single narrative about South African nurses. They do have agency, they have power, even sometimes if they think they do not have power, and they exercise leadership in different spaces. So the first thing I want to do is to pay tribute to the thousands of nurses who make a difference to the lives of patients and communities and to the South African health system every day. My tribute goes to the many nurses who are, firstly, caring, compassionate, and competent, working against the odds to provide the best possible care, especially in rural and other underserved areas. The nurses who are role models, mentors, teachers, and team players. The nurses who are leaders and trailblazers. The nurses who are women's rights and social justice advocates. If we had time this afternoon, I'm sure each of us could call out the names of people who come to mind in each of these categories. Please use the time during the webinar to remember these nurses and to acknowledge them, even if silently. But I also want to encourage you who are listening into this webinar to celebrate your own achievements in nursing and as a nurse or as an advocate for nurses and nursing. This RHAP webinar is also about confronting the problems that South African nurses face. Earlier, I mentioned that the COVID-19 pandemic has exposed the inequities and injustices of our society. In the case of the health system, the COVID-19 pandemic has accentuated the fragility and what I call the fault lines of the healthcare system. So how do we approach a discussion on social accountability in nursing education? In our context, social accountability means that there is an obligation of nursing education institutions to direct their education, their research and service activities towards addressing the priority health concerns of the community and/or South Africa as a whole, identified jointly by a range of relevant stakeholders, including the public at large. The State of the World Nursing Report, which was released on World Health Day on the 7th of April this year, calls for an investment, and I quote, in the massive acceleration of nursing education. That includes educators, infrastructure, and students to address global needs, meeting specific country demands, and respond to both changing technologies and advancing models of integrated health and social care. This investment is in addition to the creation of new nursing jobs, as well as strengthening of nurse leadership. In the South African public health sector, nurses constitute 56% of all healthcare providers. And this figure changes with as high as around 62% in the Eastern Cape province. Different modeling exercises all project both current and future shortages of nursing. So there can be no doubt in anybody's mind that nurses are central to addressing the complex burden of disease, the primary healthcare approach, and also nurses are central to improving the performance of the South African health system. Despite this reality, South Africa lacks agreed upon national staffing norms. The nursing curriculum changes have been slow, and they remain largely unresponsive to population and health system needs, and there's insufficient investment and/or prioritization of these nursing reforms. The discourse on social accountability remains largely focused on medical education. Both Dr. Mkhize and I were part of a ministerial task team on nursing education and practice. The report that was released in April 2013 has since expired, but we made quite wide-ranging recommendations for the transformation of nursing education, including clinical nursing. Very few, I hope that you'll pick up on this discussion, but very few, if any, of our recommendations have been implemented. The proposed nursing education reforms that are based on the 2013 framework for nursing qualifications remain contested, and there's insufficient stewardship of the overall transformation process. The scope of practice regulations, which can't be seen in isolation of nursing education reforms, were only released last month on the 12th of May, International Nurses Day, in the middle of the lockdown with only 1 month for inputs. So if anybody in this audience was interested in making inputs on the scope of practice regulations, then I have bad news in that you've lost the opportunity already. It's difficult when one looks at the scope of practice regulations, it's difficult to see the alignment between nursing education reforms and the proposed national health insurance system. Of course, we're having a discussion about nursing education, but I just want to highlight that one can't look at education in isolation of other aspects such as working conditions, positive practice environment, the necessary resources and supportive people management and leadership. So what are the possible actions for the Rural Health Advocacy Project, for nurses representative organizations, for individual nurses, and for health and social justice activists? All of us agree that nurses are central to universal health coverage reforms and a comprehensive response to the current COVID-19 pandemic. The International Year of the Nurse and Midwife provides an opportunity to value nurses and to invest in a sustainable manner in nursing. This suggests a broader discourse on and demands for social accountability in nursing education, which would make nursing education the business of the public and not just those in the corridors of power. Social accountable nursing education must instill in every nurse and or midwife the values and the practice of responsive and respectful healthcare. We should emphasize the transformative potential of education and training, both in building the next generation of nurses and in making a difference to the lives of communities. Nursing education must ensure a balance between caring and compassion of nurses on the one hand and clinical competence on the other hand. It is possible for every individual nurse to make a difference by providing safe, quality clinical care and by striving to be responsive to the needs of patients and communities. Socially accountable nursing education must also encourage critical thinking and instill a passion and desire for lifelong learning. This means that every nurse should take responsibility for his or her own learning to maintain competence and to provide care to the highest standards of professional conduct based on ethical principles. Socially accountable nursing education also involves the teaching of advocacy skills to overcome the structural and organizational problems which influence nurses' ability to provide high quality care, as well as teaching of the social determinants of health. What do I mean by the social determinants of health? Those aspects that fall outside the health system, but which are critical in order to improve population health outcomes. They include aspects such as water and sanitation, include aspects such as nutrition, income, the environment, and dealing, of course, with discrimination and stigma. As the majority of nurses are women, nurses should also advocate against gender-based violence and highlight the linkages between women's health and gender-based violence and the importance of ensuring that the rights of women are respected. Socially accountable nursing education also involves advocacy for the rights of women, for the rights of, for human rights in general, for equity and social justice, and ensuring access to quality care for those most vulnerable in society. These include poor people, rural communities, vulnerability on the basis of illness or disease, vulnerability on the basis of citizenship, vulnerability on the basis of being classified as the other. Finally, socially accountable nursing education must emphasize the importance of teamwork and leadership in ensuring population health outcomes. Colleagues, in conclusion, empowering and investing in nurses and nursing will have the additional benefits of accelerating progress towards the Sustainable Development Goals on health, quality education, gender equality, and decent work and inclusive growth. I thank you for listening to me.
Thank you very much, Prof Rispel. Those are very key takeouts in what you've just said. You know, I really am just thinking about all the social determinants of health that we are currently facing today, and how much nurses can impact or rather play a role in these issues as midwives, as psychiatric nurses, as primary healthcare nurses, and that indeed investing in nurses can never really be a futile exercise. I'd like to move along to the next session of our program, where we will have a panel discussion, and our next speaker is Dr. Sipho Wellington Mkhize, and I would just like to introduce him. Dr. Sipho Mkhize is an experienced and dynamic nurse practitioner, educator, and executive manager that has been in the nursing education and training environment as from 1993 up until 1998, whereby he was involved with students for basic and postgraduate programs, lecturing and accompaniment. He then progressed to be a principal of the nursing college from 2000 until 2011, overseeing the lecturers, administrative personnel, and students who were registered for basic and postgraduate programs. He's a senior manager in education training of the South African Nursing Council he was from 2011 until 2016, overseeing accreditation, assessment, and registration processes. He was appointed to serve in the ministerial talks team to develop nursing education, training, and practice strategy from 2012 up until 2016. Dr. Sipho Mkhize is currently working as a lecturer and a supervisor for master's and PhD students at the University of KwaZulu-Natal Howard College campus in the School of Nursing and Public Health from 2017 up until to date. He has also been reappointed to serve as a ministerial task team to review the nursing education and practice strategy with an aim to develop a new one for the next 5 years. So it is my honor to introduce Dr. Sipho Mkhize. Sir, you may have your platform. Thank you.
Thank you very much, Lungile, and good afternoon to everyone who's listening to me and also the members of this. Thank you. Am I audible enough?
Yes, you are, sir. Yes, you are, Dr. Mkhize.
Thank you very much, because there was a change on sharing the screen. Okay, thank you very much. Sorry for that hiccup. I was just saying that thank you very much for introducing me, as well as also the keynote address by Professor Rispel. As one of the panelists, I'm just going to bring in just few summary of what has been said in a keynote address, which I've just divided into two areas. I said it's the key tenets as well as the focal areas. Now, the key tenets around nursing, as it has been said, it's about caring and compassion, clinical competence, clinical and reflective thinking, a desire for lifelong learning, stewardship, and leadership. Now, when we're talking about transforming nursing education at this time, the main point is around social accountability. The reason being that we are at the time when things happened when we were least expecting. As Prof Rispel has said, that there was framework that came in 2013, which came up with also a number of regulations that were promulgated in order to have a better nurse that will be produced. But down the line, those curriculum that were developed, it's only that the students or the first cohort, it's in this year, which is 2020, which against that background, there is a need that we need to say, how do we transform in order to meet the needs of the country and the changing and the dynamics that take place amongst ourselves. So the discussion around this, or to summarize and to make the public aware, the nurses and advocate for nursing, is that we must also need to look at teaching and learning. We are in a state right now where we never thought that there will be a time where we cannot deliver traditional teaching. But now, because of the COVID-19, it means we need to change our strategy. Now, as nursing education is being reformed, how ready are we and what can we do in order to make sure that much as we've got reforms in nursing, but how that can be delivered to the students and the people out there so that they can be able to benefit. Another issue that is within the keynote address that we also need to think about and think very carefully as we debate is the issue of the clinical training platform. We have it, and she mentioned something around the social accountability that we're still leaning towards the medical education, which is more hospital-based and very little in terms of how to prepare people that can go and meet the needs of the rural communities and those areas where healthcare is inaccessible. So that is another a mindset or a paradigm that we need to go through and talk about it as to say, how do we deal with that? Then in my closing and my closing around on this is that we need to ask ourselves, how do we respond to the changing and dynamic society, as well as the health that is, it should be taken care of, because being a nurse, the role is that you must be educated, and the education is a right for any human being, as well as health, it is a right for any human being. So these two processes, education and nursing, which brings in health, it's about how human right can be attained. So with that, I would like to pause and give it to other panelists to speak. Thank you very much.
Thank you very much, Dr. Mkhize. Thank you very much for that. A key takeout for me from what you've just said is just about how we need a paradigm shift, rather, from a hospital-centric type of approach to a more primary healthcare, community healthcare orientated approach towards the delivery of healthcare in South Africa. And, you know, I'm just thinking also about how the plight of the gender-based violence that we are currently faced with, and how rural communities are affected, you know, because of this, and how primary healthcare is mostly the first port of call for most rural communities. And it's just really dawning on me how important, or rather how we really need to invest in this kind of healthcare paradigm. I'd like to further introduce our next speaker, Dr. Gwen Lawrence, who we are very honored to also have today. Dr. Gwen Lawrence is currently the National Chairperson of RUNURSA, the Rural Nursing South Africa, rather. She's also a nursing manager at Evergreen Health and affiliated to the Faculty of Medicine and Health Sciences at the Stellenbosch University in the Department of Nursing as a research supervisor, and Ukwanda Center for Rural Health as a research fellow. She holds a nursing degree from nursing at Stellenbosch University and Tygerberg Hospital as a general psychiatric and community health nurse and midwife, and has a postgraduate qualification in management and education, occupational health, nursing and primary health care, a nursing master's and a PhD in public health care management. She started her career in comprehensive health, mobile clinic, and community psychiatry. She has held a senior health training portfolio for Bowen District Municipality, ran a national TB HIV project from CPUT, serves the Department of Health as a quality manager of a 300-bed hospital, and managed a national health hospital revitalization project, as well as the Ukwanda Center for Rural Health and the clinical training platform for the Faculty of Medicine and Health Sciences at Stellenbosch University, where she later headed up the postgraduate nursing education program for the nursing department, and was appointed in 2019 to the newly established Evergreen Health of the AMDAC holding company in nursing management role inspired by RHAP, Rudasa, Rurisa, Pakasa. She was one of the founding members of RUNURSA to strengthen leadership in rural health nursing. Her core value is respect, and the nursing profession has at its core the utmost respect for human life. Dr. Gwen stays in Paarl and has a cheesemaker husband and two young adult sons. So it is my honor to welcome Dr. Gwen Lawrence. Over to you, ma'am.
Good afternoon. Thank you very much for that introduction. And I also want to acknowledge RHAP for their continued commitment to rural health matters by hosting this webinar. And also to Prof Rispel, who's one of my South African nursing icons. Your keynote distills the fragments which we need to assemble to find our way to a future of the nursing profession. And it's particularly a professional nursing profession. I also want to acknowledge my fellow panelists, as well as those that are listening kindly to that path that we want to find towards a transformed system in which nursing can take the celebration of the nurse far beyond this year. Excuse me, let me have a sip of my coffee. So, as mentioned, I'm wearing a few hats on this particular panel, so I've added them all onto this slide so that I acknowledge everyone that I'm affiliated to. But obviously our focus is on education, and I would just like to respond with a few extra pointers to what Prof Rispel has already said. So in terms of RUNURSA, RUNURSA aims to strengthen leadership in nursing, and particularly in the rural areas where there is still a great need for the voices to be heard and for people to take leadership and advocate for rural nurses. In nursing education, specifically, besides the massive upskilling that is required with the necessary resources attached, there also comes a call to produce a practitioner who exits after a transformative learning experience with graduate attributes and clinical competencies for ComServe and beyond. So maybe it's the Stellenbosch bias, but the adapted CanMed's graduate attributes, which have been accepted by the Health Professions Councils of South Africa, is well suited for nursing curriculum and is something that should be considered. So through these graduate attributes, which I've indicated in the blue arrows of my slide, we can develop leaders and managers that we need to improve healthcare governance and inspire healthcare workers in the challenges faced every day in the workplace, especially in rural realities. I've placed there above the leader and manager. I also firmly support that golden triangle of quality of healthcare, effective infection prevention and control, and occupational health and safety, which should also contain the mental well-being of nurses. And I think that that can certainly be woven into curriculum and capacity development. And even with a focus to primary healthcare, I think it's even more crucial that those components are included in our primary healthcare re-engineering. So going on with these graduate attributes, we need to promote teamwork and interprofessional care through the development of collaboration and communication. So I know it's a bit of a cliche, but I say bloom where you are planted, and we must certainly collaborate with our industry stakeholders in a spirit of sharing and generativity. So it's in the giving that we grow ourselves and others. So in a recent article that I read, we need to lean in and support other nurses. During these trying times, we cannot sit on information, especially in our COVID-19 response. We need to share with others and share what we've developed, because the time is too short to sort of hold information that others could benefit from. I think there has been a great spirit of sharing, but that sense of collaboration needs to include. So the scholar should emerge from nursing education on a trajectory of lifelong learning. Above all, I would say for the discussion today is that attribute of advocacy, or developing an advocate through nursing education, not only for the patient, but also for the community, the nursing profession itself, and the voice of the nurse should be heard in the fights against femicide, intimate partner violence, and inequity alike. Then one of my other slides is about the shapes, if you like, is the HR alignment. And the international shortage of nurses, also mentioned by Prof Rispel, is compounded in rural communities, where often only 1 out of every 2 nursing posts are filled. And despite this, the healthcare service packages keep expanding, the involvement of more and more to the advanced clinical nurse practitioner, and health facilities upgrades continue unabated and bring in new clinical areas. This, however, is frequently with a lack of HR alignment or human capital alignment to these increases. And being the backbone of healthcare delivery at over 50% of the healthcare workforce, the staff shortage pinch is usually felt most by nurses. So then there's also the pragmatist in me that cannot ignore basic logistics that drive nurses away from rural environments and let us struggle with retention. And it's really as basic as acceptable accommodation. I haven't traveled extensively, but to some of the rural areas that I have been, I salute the nurses that I've met there in rural spaces, and they carry on despite very poor housing solutions and unsafe and unsatisfactory work environments. And this needs to be illuminated for positive change. So we need to ask ourselves, what makes nurses walk away or stay? And then actively seek what are those self-actualizing factors that we can support to create career pathways alongside organizational training and development, with change management strategies to hold and care for nurses through often chaotic, disrupting healthcare shifts. And then finally, I just want to say that I do also believe in a value-driven approach to growing nurses, from the neophyte to the clinical specialist or leader and manager. And values will serve to inform care and clinical practice. So as mentioned in my introduction, at the core of our profession is the utmost respect for human life. We must respect all life and support initiatives that advocate for respect for life. And so a value such as respect, which I always propose, can form the basis of ethical professional conduct, which is so needed to care for ourselves and our communities and those entrusted in our care. Thank you very much.
Thank you very much, Dr. Gwen, for that. I really do commend you as a rural nurse advocate. It certainly isn't a very easy role to play, and I think it is good to have such associations that sort of represent rural nursing. And I think, you know, to all our rural nurses listening on this platform, I really do encourage you to use it and do contact Dr. Gwen for more information around her association that she has founded. And in spirit of Youth Month, we have our last 2 panel members. I'm going to introduce Lerato Madumo right now, who's the current president of the Young Nurses Indaba Trade Union. And I think also, you know, if you're talking about responsiveness to communities, it's also very important to speak about just being responsive to the cries of our nurses because there certainly are cries, and I think Lerato Madumo would be a good person to sort of share her bit on these issues. And I will just go ahead and introduce Lerato. Lerato is the founder and president of Young Nurses Indaba Trade Union. She is a nurse educator who is a subject expert in mental health, psychiatric nursing science. She has extensive senior managerial private health sector experience in emergency medical care and has managed healthcare and customer service with information technology IT background. Lerato is also a former occupational well SA director and has served on various nursing and health commissions. She is the member of the ministerial task team on the review of the nursing strategy, the vocal and fearless activist in health and nursing politics. She is a passionate professional public speaker who has the vision to unite nurses in the restoration of the image of their own profession through empowerment. Over to you, Lerato. Thank you.
Hi, thank you, Lukhele. And let me greet all the panelists in this webinar, and all the 56 participants. I think last I checked, that's where we were at, and everybody that's actually watching us on Facebook Live currently. The topic that we are tasked to be discussing today is really relatively something that is very close to the nursing community. Everybody always wants to know the future of nursing in SA. And it's an uncertain future because we are currently, if you look at the nursing education and training currently, and it's transitioning from being under the auspices of healthcare, going into higher education. It's a very uncertain terrain. It's uncharted terrain that we've never seen ourselves in, and it has brought a lot of uncertainty around academics, around students, around the nursing fraternity. Just right now where we are, and I think it will be a miscarriage if I do not say revolutionary year of the nurse to all the nurses of South Africa and the nurses of the world. And it has been really the year of the nurse. To be genuinely honest, looking at the historic and nature of our profession, one would ask, how do we even begin to celebrate nursing? How do you even begin to put nursing in the spotlight? But ironically, in this year of the nurse, we have found communities, we have found the fraternity itself, we actually found the globe sitting down and really zooming into the nursing profession itself. And currently, the state of our profession, it's not in a rosy picture. I think I speak quite at length about the issue of that. It's not a glamorous profession because it is plagued with so many threats and so many challenges. But amidst that, it doesn't mean we do not have a whole lot of opportunities and strength as a profession. And this year particularly, it has drawn our attention and it has said, let's sit down and look at where we are going. Just on the first, I want to talk on 3 things, particularly in my address. I want to talk on the nursing education and training. I also want to talk on the profession itself, which is the practice. And thirdly, I want to talk on the regulation of the profession. Like I said, everybody knows that we've seen a lot of gazettes being out. And notoriously, they had even, our very scope of practice had to be, gazetted out for public commentary and even be proved back within this very time frame. And ironically, it was on the 12th of May, which is Nurses' Day. But when you look currently, there's a lot of school of thought around the future of nursing. And I'm saying our global topic here is the future of nursing education. We are transitioning to your R171, R174, R169, which are the current curriculums, that are the regulations that are going to be within the training and education space. there's a school of thought of saying, yes, we need to go into higher education. Everybody is of that opinion. But the reality is the how part. A lot of our young nurse cadres and those who are academics in this are saying, this is not the right way of going about it. In fact, we have looked at the Cecilia Makiwani type of training, and we have just literally hotspotted ourselves on something like that, where nursing should be improving, becoming more comprehensive to speak to the needs of the rural communities that we serve, to speak to the needs of the urban communities that we serve. So we from 1986, if you follow properly the history of nursing, you'll realize that we have been in a comprehensive space where once our nurse has been, that cadre that we have trained can be placed everywhere. But currently where we are looking at where we want to create more generalists amidst the disease profile that we are facing, where mental health is ranging so badly and high within our communities, where we need more community nurses, where we need to have more PhD engineering, hands-on nurses. Here we are, the curriculum that we have designed is there creating a nurse generalist and a midwife. And where do we leave all this other much needed specialties? There's a gazette that was also released that is currently, becoming a thorn in the profession's needs, and that for sure is around the PhDs, around the postgraduate diplomas. And when you look at it, we are again narrowing down. It looks as if we are becoming less of specialists in specific fields, but more of specialized in absolutely everything. And that approach is something that is debatable. And when we talk about the future of nursing, the young nurses in this country it's an uncomfortable debate, but it's something that we need to look at, because most of us don't believe that we are definitely moving in the right direction as a profession, and the future of our profession is really at stake. The second thing I want to look at is the pandemic. I think the pandemic in the practice has exposed us that we already walked into this pandemic with an ailing healthcare system, with a nursing profession that was really at its worst position. The image of the profession was at its most tarnished level. And where we are currently, all we are dealing with is the gaps and the lacks of this current profession that's supposed to be a caring profession, but that's not exactly what we are experiencing. And unfortunately, it needs us to take stock. We need to sit down and we need to really regroup and say, genuinely, as the nursing fraternity, have we been doing right, even before the pandemic? And the answer is a straightforward no. We've not been doing right by our patients. We've not been doing right by ourselves. We actually have not been doing right for advocating for self. And I always find this narrative to say, genuinely as a nurse, I cannot claim to be a patient advocate when I cannot be an advocate for self, and I cannot be advocate for my own colleagues, and I cannot be an advocate for my own profession. The patient becomes at a worse off position because you have an advocate that is already very much compromised. And within the profession and the practice itself, we have become accustomed to improvising. We've become accustomed to just saying, that's how we found it. And we have little to no regard of wanting to see really this profession, this caring profession. I won't use the word returning to its former glorious days because I don't actually subscribe to that narrative. But just to say, we need to be seeing nursing moving in a different in a different light altogether. So we need a new era of nursing, and we've never been in the fourth industrial revolution as a nursing fraternity. We're still way back. If you compare us with other healthcare professionals, nursing alone is still sitting in really the bundles in the papers and the pens. We're still grappling with technology. And I think in education, it actually exposed us as academics. It was sad to see that the online we're talking about was not Zoom, was not Microsoft Teams. We were literally have to be subjected to educating on WhatsApp. I mean, how do you call WhatsApp online with 300 and plus students that we are doing online teaching? It just exposed that there is a lot of technology that we need to pull back within us. Finally, when we talk about the regulation of nursing. And I think in the past weeks, even during the lockdown, our regulatory body became very much on the spotlight. It became very much on the spotlight in the public domain, where the profession itself began to ask the relevance of its regulatory body. We saw it even with the very scope of practice that was released and retracted when they received the pushback. We are looking at a regulatory body that looks like it's not in touch with what is happening on the ground. A regulatory body that is so detached from the profession itself that even during a pandemic, it could not be palpable. So it is exactly those concerns around the profession that I feel that these are debates and these are topics that we cannot ignore. It's good and well to come and have a very academic conversation around nursing, but it needs us to really, nip the nuts and bolts of what is making this profession to be such a backwards and not so progressive in its current nature. And I think I will pause there if I've not exhausted the time that was allocated to me.
Thank you very much, Lerato. Hugh, that was a lot, and I think we did quite hear Lerato on her very passionate points that she made about nursing. Nursing is the backbone, they say, of the healthcare system. So I think more than ever, we really, I think this is the third time I'm even saying this today, but more than ever, we really need to invest in nursing in order to really strengthen this backbone. And I do thank you, Lerato, for your for your points. And I'd like to move along to our next speaker, Sanele Lukhele, who is also a very young nursing academic in her own right. And yes, I am really just happy to have such a diverse panel and speaker list. And I'd just like to move along as we introduce Sanele. Sanele is a lecturer in the nursing department at the University of Johannesburg. Sanele holds a master's degree in midwifery and neonatal nursing science. Her areas of interest are maternal and child health, as well as indigenous knowledge systems. She is so passionate about nursing scholarship that she co-founded the South African Students Association. This is a non-profit organization aimed at uniting nursing students across the country in order to improve the image of nursing in the country. In 2017, the international community recognized her as she was invited to be Africa's sole representative in the Sigma Nursing Next Generation Leaders 8-member task force. In 2018, Sanele made it onto the Mail and Guardian 200 Young South African list, an honor that she has dedicated to all nurses who have made it their mandate to restore the image of nursing in South Africa. In 2019, she was awarded the Premier's Excellence Award in the health category. Sanele is a passionate midwife who always advocates for midwifery-led care for all low-risk women, especially those in the private sector. She has made it her passion to educate those within her reach on social media about midwifery-led care. Sanele was honored this year when she had the privilege of birthing with a midwife. This experience made her even more determined to advocate for midwifery-led care. Sanele, I'd like to hand it over to you. Thank you.
Good evening, ladies and gentlemen. I would like to thank Lungi for the invitation to be on the panel today. I'm very humbled for the invitation. I will just go into the address that I've prepared. So 2020 has seen the implementation of the new nursing curriculum, R169 for auxiliary nurses, R171 for staff nurses, and R174 for professional nurses and midwives. This comes an entire decade after the initial deadline announced by the South African National Nursing Council for the phasing out of the legacy qualifications. The two most important distinctions between the old and new curriculum is that the requirement for the registration as a professional nurse and midwife is now a degree. The staff nurse will now be trained for 3 years, resulting in a diploma. This curriculum also comes 10 years after the Human Resources for Health report was published, this report emphasized the need for training of more midwives. The report also introduced the model to be used for the implementation of the re-engineering of primary healthcare in the country. Re-engineering of primary healthcare is underpinned by 5 nurse specialities, which are midwives, primary healthcare, community, and pediatric nurses. These nurse specialists have been deemed central to addressing the burden of non-communicable diseases, maternal mortality, and under 5 mortality rates through various programs. I've noted with great concern that the new curriculum seeks to train a generalist nurse, as Lerato has just said, and midwife. It seems that while the country's health policies are moving in the direction of preventative care at a primary healthcare level, nursing education is going backwards and keeping us in the hospital with a curative model. Research has stated that the rationale for the changes is that the comprehensive basic program has been criticized for using a content-based approach instead of a competency-based approach. The comprehensive qualification entailed excessive training in all 4 areas of care, while ill-equipping graduates for competent practice in all these areas, particularly midwifery. The South African midwifery curriculum remains a huge concern for the nursing profession. When benchmarked with other African countries in terms of experiential learning, South Africa lags behind, terribly so. African countries such as Uganda, Rwanda, and Malawi have a direct entry midwifery program where qualifying midwives are expected to conduct between 50 and 70 births in order to qualify as midwives. The midwifery programs there can span between 3 to 4 years, depending on the country and the type of qualification. In South Africa, on the other hand, midwifery is taught over 2 years and may be interrupted by other modules from other specialities within those 2 years. Qualifying midwives are expected to conduct a mere 15 births in order to qualify as midwives. In light of this, we have to ask ourselves if our attempt to train a more competent midwife will have the desired impact. Regarding the issue of psychiatric nursing, it is worrying that students will only do a short introduction to the subject. In the face of a rising unemployment rate in the country and disease burden caused by trauma such as gender-based violence, it is highly probable that the demand for a nurse graduate with a solid psychiatric background will increase. The World Health Organization estimates that 1 in 4 people will suffer from a psychiatric illness at some point in their lives. This then begs the question of how responsive the new curriculum is to the disease burden in the country. The malabsorption of ComServes in the public health sector remains an ever-present concern. COVID-19 saw National Treasury making funds available to employ nurses in posts which were previously frozen. While this move is welcomed, as nurse educators, we have to ask ourselves if we are really training independent practitioners who are able to be entrepreneurs within the health sector. An emphasis on community health nursing in nursing curricula will not only be in line with the country's move towards promotion of health at community level, but more importantly, it affords unemployed, newly qualified nurses with the opportunity to use their expertise to service the community in which they live while generating an income. In conclusion, I would like to end off by sharing a contribution made by a professional nurse who was raised in Gauteng and also trained as a nursing student at a university in Gauteng. She is now working in rural KZN and had this to say when I asked for her inputs on today's topic, and I quote, "Most, if not all, our nursing colleges and universities are based in urban or semi-urban areas, meaning that even students that come from rural areas are going to be exposed to a different environment during their learning and training in these institutions. We know that there are modules that seek to sensitize the nursing student to the different cultures, traditions, and norms within our society. But how far does this sensitization go, and is it effective? Is it enough to give a lecture on issues pertaining to health affecting recipients of our services in the rural areas, or should more be done to educate the nurse who may or may have never served or received a service at a rural hospital, clinic, or facility, end quote. She goes on to give the following suggestions regarding nursing curricula. Increase the amount of time and intensity with which students are placed in rural communities. Also, give preference to students who come from previously disadvantaged backgrounds and rural areas who have an interest in nursing and do qualify. This will mean that they will be equipped with the necessary information and skills to better serve their rural communities. Upon completion of their studies, they can take the knowledge and expertise that they have gained back to their communities. The observations and suggestions made by this young nurse are echoed in a study done by Mkhize in 2009, who found that nursing education institutions use tertiary, high technology, well-resourced, ideal urban hospitals as the main setting for the placement of the students. This, however, deprives the students of exposure to rural and under-resourced health settings, which were serving a larger percentage of the population. Furthermore, this led to the production of large quantities of highly skilled technical nurses who were only able to serve the minority of the population that had access to or who could afford services rendered in high technology hospital. The major shortfall of this practice is poor retention of graduates in rural and under-resourced settings, leading to skewed distribution of health personnel, as in this extract. In conclusion, I would like to say perhaps partnerships can be forged between urban and rural nursing education institutions to facilitate an exchange program which not only exposes those students who are training in urban areas with an opportunity to engage with rural facilities and communities, but also affords students training in rural areas the opportunity to see how urban health services are conducted. South Africa is an interesting country with well-developed, developing, and underdeveloped areas. I propose exchange of students in the country between the University of Venda and the University of Johannesburg, between WITS and UKZN, to enable students to learn both rural and urban methods of nursing care. Thank you.
Thank you. Thank you very much, Sanele. I think I completely resonate with your points, particularly the one about, retention strategies for rural healthcare. As a nurse myself who has practiced in a rural clinic, I can definitely say that, that experience did help me. And I guess also training in a very urban setting, it was a little bit of a hard transition for me to work there, but I am grateful nevertheless for the rural experience. And also my heart also does cry out to the lack of, or rather just or perhaps maybe I might just need more explanation on this point, but rather on the competency of psychiatric nursing at the end of the 4-year nursing training, and what implications that will have in, for example, rural communities or just PHC in general. So thank you for your point, Sister Sanele. I'd also just like to give a minute or two to another young nursing student who's so passionate about this profession. His name is Nathaniel. Just a minute or two, Nathaniel, if you're still there, just to give your word on just your experience thus far as a nursing student. Over to you, Nathaniel. Okay, Nathaniel? Okay, I would just further propose that we have we move along to our Q&A session where we can just engage with the panel members. So if there's anyone in the audience, I'd like to give that platform to you to sort of audibly raise a question to our speakers today. Okay, or perhaps we can start with the questions on the chat box. We have a question here by Lynn Chosent. She says, I understand that the Gazette changing the scope in May was retracted as the wrong version was published. I'm yet to see a replacement. So I'm not sure if Lerato, you perhaps have a word or two to say, as you had mentioned that, or Prof Rispel.
Hi, yes, are you able to hear me audibly?
Yes, Lerato.
All right, excellent. I think just been reading the comments that we're getting on Facebook Live, as well as the participants here. I think the general feel that I actually get is, the need and the deep-seated need for the nursing profession to begin to embrace the culture of moving to the new. And, whether be it that we are from the old school of thought or we are the new or young or old, we need to be able to say, this profession really needs to revolutionize. This profession needs to decolonize. And the way it's viewed, we cannot allow anything that deprofessionalizes nursing today, whether be it from the education side of things, whether be it in the clinical practice itself, or anything that actually demotes nursing. Because if you look at the healthcare system currently, and I'm listening to my learned colleagues throwing statistics around, and to be honest, and I normally make jokes around, once people start calling you backbone and they're calling you the brain, is when they really want to exploit you. But on a serious note, we need to make sure that this biggest component of health, that is nursing, which has been carrying us even through this pandemic, needs to begin to be taken very seriously. Not seriously just on paper, but even in the way we recognize them, we pay them, we see how we need to move them academically. We cannot have a profession that is just having plateauing and stopping at people being just RNs. When every other profession, one can go up to doctoral level. And I'm not talking about a doctoral level that is not even recognized by your own regulatory body, or a master's degree that is not recognized by your own regulatory body. We need to be pushing and fighting that nursing is actually our model. And this model needs to be better than anything than can be offered by any other country, be it Cuba or whatever. And our primary healthcare and our specialists in nursing, they should be recognized as such and be compensated as such. And unless we really are deliberate and we are intentional about progressing nursing, we will forever be finding ourselves in the back foot and being a sub-profession in the healthcare industry. Yet we are actually the administrators and the managers of this healthcare system, and we still cannot just be the biggest, but the most useless component. We need to be the biggest and a force to be reckoned with if we are to change the landscape of our healthcare system.
Thank you for that, Sister Lerato. Yes, and I think also in light of Youth Month, what are those like retention or attraction strategies that we can use to sort of attract younger nurses into the profession? And I think that also brings me to the next comment by Ramona Azaxaba that says, I think Sister Lerato brings up a very important point when she speaks of advocacy. How do we foster, sorry about that. Mr. Bona. Okay, so the question says, how do we foster advocacy? Yes, how do we foster advocacy as a culture amongst practicing and student nurses? There seems to be a hierarchy within the various healthcare settings, which seemingly renders a large majority of nurses unable to advocate for themselves and yet alone their patients. How do we change the mindset of existing nursing professionals and mold the upcoming nurse to not accept things as they are because they have already been done that way?
Look, yeah, Lungile, the hierarchical system is a problem because that is an apartheid system. You know, I say so boldly that is an apartheid system because today you will never find an auxiliary doctor. There is no auxiliary dentist. In nursing, you want to have a high layered levels of assistant nurse, enrolled nurse, RN. For me, that is unnecessary. We need to have a formidable force of registered nurses, and that's how the curriculum must be. Registered nurses that will branch out and become specialists. That will then begin to speak to the needs of our communities. Then we'll begin to speak to progress in nursing. Once we begin and want to have semi-nurses, auxiliary nurses, care, auxiliary nursing, that's where you begin to have a profession that looks like it does have no direction. Hence, we are vehemently, as young nurses in Indaba, vehemently opposed of having this 169, 171. It's unnecessary. Let's create a cadre of a nurse that is so articulate, that is fearless in their approach, and they're able to speak to the needs of our country here and now as it happens. But at the same time, we need to be very cautioned to say we need to be attracting the right people into our profession, people who are really caring, people that really wants to see this profession really growing and not wanting to say, because during my time I only did a certain course, therefore everybody else that comes after me will not be able to benefit at an advanced level of nursing, and that is what is killing us. But your earlier question before I answered this one, you were asking about how do we get young people into nursing? And I think one of our greatest missions is the restoration of the image of our profession. I mean, we grew up knowing that nursing is glamorous, but the minute it is tainted by bad publicity, it is tainted by bad apples and bad potatoes in our profession, we then begin to lose our glory. And I think it's important that as a nurse, we begin a culture where we say, not in my name, not in a nurse's name, because when others are behaving in an odd manner, in a manner that is not caring, we sometimes keep quiet and forget to advocate. And when you forget to advocate for that particular patient against your fellow nurse, it's when you perpetuate a culture of saying it's okay that patients must be treated in a manner that is not acceptable. And as a result, everybody that begins to look at nursing as one of those, the most horrible professions. But I'm not despondent. I have so much faith in the fact that if we continue and we keep on, reprimanding one another, we continue advocating for one another, we continue conscientizing one another, we have somewhere that we are going.
Okay, thank you very much for that, Sister Lerato. We also have another question that's posed to all our speakers. It asks, how can nurses be better supported to boost their morale and the challenging environment nurses work in, particularly in the rural context? This question was asked by Tokozile. Yes, perhaps I think it's just a general question for all our speakers. Thank you.
Hi, Lungi, maybe I can take it and then other panelists can come in. Today's debate is important because we're talking about nurses who certainly are the largest group of trained healthcare providers in South Africa. if we really look at the issue of support toko, you can't separate it from the support that's needed for health workers in general. So it has to be addressed fundamentally at the level of the of the healthcare system. And if you notwithstanding Lerato's desire not to talk about statistics or what she talks about, not to become academic about it. The reality is that there is underinvestment in human resources for health in general. And there is a refusal to acknowledge that unless you address fundamentally the issues of the people who provide healthcare, we're not going to have a well-functioning health system. And in this instance, I will use the two seminal reports that were developed in 2016. The one was from what was called a high-level commission on health, employment and economic growth. And they called for an investment at country level in human resources for health. They also said that for every health worker that you employ, you create jobs for 3 or 4 other people, which means that if you invest in health workers, you also invest in economic growth. What we've seen in the public sector in South Africa is actually the reverse, Before the COVID pandemic, those of you that watched the Minister of Finance's speech would have seen that there was a real decline in the budgets of health services. So one of the things that I hope, one of the positive things that I hope would come out of this tragedy is that the tragedy of COVID-19 is that there would be a recognition of the Minister of Finance that he needs to invest in the health system and that he needs to increase the budgets of the public sector budgets, both for health, education, and social development. That you cannot implement austerity measures and hope that you're going to be able to manage the pandemic and the fallouts of the pandemic. Once you have investment, in human resources, it goes hand in hand with better working conditions. So, for example, making sure that health workers are safe when they work, making sure that that there's enough essential medicines in facilities, whether it's a clinic or a hospital, making sure that that essential posts are filled and that the nurse doesn't have to end up doing the work of 3 other health workers, making sure, for example, that management both understands and invest in health workers. So Toko, I don't think that the question, your question, has got a straightforward answer, and that straightforward answer, I would say, it's the importance of the Minister of Finance and the country as a whole investing in the health system and recognizing that when you invest in the health system, it's not actually sunk expenditure, that you're also investing in future economic growth apart from investing in population health outcomes. That's what I think we should be lobbying for. That's what I think we should be protesting for, that this pandemic has highlighted the importance of investing in the health system.
Thank you. So, sorry, Dr. Good, you may go.
No, fine. Yeah, I thought I would also just add a few things. I know that it was also said, not in my name, but another mantra that I think is helpful is nothing about you without you. Because one of the other questions posed here is, how is this kind of planning still going ahead that affects nurses dramatically without nurses being involved in the planning? And when I did my doctoral study, and I continue to see it in the private sector and in the public sector, is that facilities, services all kinds of things are planned where nurses have to spend 99% of their days in, and yet there's not nursing representation on these planning committees, design committees, and certainly not in the HR budget, as Prof was saying. So yeah, I think that one of the other questions or comments here, I think it was by a student nurse, who said that you know, they are hoping against hope that the pandemic will put nurses on the map, that people will recognize us. And I think a lot of us hold that hope as well, is that now all of a sudden posts that have been lying dormant for how long have been activated by health ministries, and now there has been funding mobilized. It's sad that we had to do it through a pandemic and a crisis and a lot of human suffering in terms of socioeconomic issues, but at least, you know, it's opening a wave, it's opening a crack so that we can get our voice in and try and advocate for our voice to be heard in the planning and in the budget allocations of human capital in terms of nursing posts. Thanks.
Thank you, Dr. Gwyn and Prof Rispel for your responses to that. We are running out of time, but we will take just a few more questions. And I think that I'm seeing right now is one from Facebook by Catherine Williams, more of a comment, but she says, what are the specific pathways to engaging with these challenges going forward? Very late, but as a mental health nurse specializing in mental health, or specializing in addiction, I want to see more mental health and psychiatric skills going forward. And I think this points to something that Sanele had said about just she alluded to the lack of mental health within the new curriculum. And I think Sister Lerato also sort of alluded to this point. So I'll just hand it over to them regarding this. Thank you.
I think Sanele, you can go first. Lungi?
Hi, Lerato.
Oh yeah, no, it's fine. Let me go first. I thought Sanele would take it first. It's exactly what the narrative I'm trying to point around the needs of the society. When we design curriculums and we design programs for teaching healthcare providers, nursing to be more specific, we need a more sincere approach that speaks to the disease profile and the disease burden. But at the same time, it should be speaking to what is the need of the profession. If you go in every community, whether be it rural or urban, or even especially in townships, you find that our greatest struggle is substance-induced everything. Literally, as a mental health care educator myself, I can tell you, it's sometimes difficult to even begin to, educate your student on DSM-5 about specific conditions, because what we see, the large population, is everything being linked to substance, whether it be anxiety, depression, bipolar, you name it, is in the text. So it says our community is struggling so heavily with this. And I think we are not taking away from the fact that in the past, and it's quite a recent past, where we had to deal with life acidemia, which proved that as a country, we are seriously battling with looking after our most vulnerable groups, which could be the most, children with disabilities, and also our aged, if we had to go there, which is still part of mental health. We are extremely exposed when it comes to those parts. So yes, we cannot just be having a profession of generalist, of one-trick ponies. We need nurses who will then begin to be able to deal and address the needs of our communities. And like I have said earlier on, and this needs to be something that is planned, and we are deliberate about it. And that doesn't only speak to mental health, it also speaks to mother and child it speaks to community nursing, it speaks to oncology, it speaks to forensic nursing, which up to today is still not recognized. And we cannot forget about the core of primary health care when we talk about PGTs. And we need to also be creative. There are, we cannot say because in the past we've always had R48 and all the listed R121 qualifications, then we are content. We need to look, earnestly and diligently at what is needed out there, and we should begin to do that. And South Africa has always been a trendsetter and has always been leading the pack when it comes to nursing care. Hence, all our nurses have always been well sought out after. In many countries, we cannot allow or agree with the standard of nursing dropping in the name of transitioning to higher education. We need to be transitioning to higher education with a proper and good quality nursing programs and curriculums.
Okay, thank you for that, Sister Lerato. Sanele, Dr. Mkhize, do you have any perhaps like addresses to address that particular point, or should we move right along to the next comment?
I think I think Lerato summed it up nicely, but also because we are already implementing this curriculum, there aren't much changes that can be made at the moment, because even for this curriculum to be implemented, there were discussions and everything for 15 years or more. So if we are to talk about a review of this curriculum, we are talking about another 30 years before anything will be implemented. I'm sorry to sound so negative. So yeah, that's my opinion. So if anyone wants to study psychiatry with this new framework, then they first have to go through the basic degree, and then thereafter do psychiatry as a postgraduate diploma. That's just how the curriculum now is structured.
Okay, thank you, Sanele. Dr. Mkhize, were you? I think you were about to say something just before Sanele had commented.
Yeah, that's true. But I said let it be ladies first. As a person, when I listen, especially when they speak around the mental health, it's something that is also very close to my heart, because before anything, I started by doing a 3-year psychiatric nursing. And that was something that was very good in order to prepare people to work in that environment. But we cannot say go back and do the 3-year course. But looking at what is currently happening with the program, because when we look at the circular that came out this year in relation the readiness of nursing education institutions in terms of offering the new programs, you find that the public colleges, which are the main drivers of the nursing program, they were for the R171, which is like the old 3-year course that I did in my time, and then start adding on as I move along. And then if you really speak of what they should be done after that, because it is at level 6 of the NQF, only the midwifery that is regulated at the moment where they can do that. Now, which means those nurses that are doing R171, if they want now to do psychiatric nursing, which would be the same like the midwifery, which the regulation is already out there to do it after 3 years. They can't do it like Lukhele has said, but they need to go and do a PG deep. Now, in terms of NQF Act, you cannot jump a level. You need to go through a particular level, then you move so that you articulate correctly. So we need to be honest about certain things that are in place and say what could be done, because we cannot say start all over again, start from afresh, because things go very far, moving from one office to the next and all the red tape that is there. But what is key is that when the public speak and the advocate for nursing and nurses speak, we need to be having ears and be able to say what it means. How do we respond to this, rather than seeing it as if it's mudslinging? So I'm in full support of when we say we need to look at how do we handle, because the topic at hand is about social accountability. Now, social accountability, it's about how do we respond to the public, which is the consumer of health. And to receive health and quality health, there must be people that are trained appropriately, and they are trained in order to make sure that they meet the needs of the country, rather than meeting the needs of a qualification, which will never be utilized efficiently. Thank you.
Thank you for that, Dr. Mkhize, Sanele, and all our panel speakers for today. So we are running very much out of time, and I think I just have one comment before we move on to the next session. We have, however, a lot of questions and comments coming through from both Facebook and the Zoom platform. So I think this does show us as the RHAP to continue with these kind of discourses going forward. It is quite a pointer that it's important issues that are being raised, and I think it really does urge us to sort of continue with these sort of discussions going forward. So I'll read a comment here. It says, according to the Van Wyk de Vries ruling, talking about the link between universities and colleges in collaboration to administer the curriculum, we should be having that collaboration in migrating nursing colleges to online learning, because universities are ahead in online learning already. That will need us to focus on the infrastructure as well. And the next point says, besides having sound issues, or rather the benefits that came with the previous funding model address the unemployment rate of young people in South Africa. And I think this, yes, this comes from a student, a nursing student, Nathaniel Mabelebele, who's also the chairperson of the NOSA. I think just moving to our next point, or rather our next session in this program, I'll just ask our speakers to perhaps say a word or two for a minute, just to close this particular discussion. Thank you. So I think Prof Rispel, you may go ahead, ma'am.
Thanks very much, Lungi. I mean, I think this is a very important discussion, but I do think I'm an eternal optimist, and I do think there are some things that can be done. So although Sanele said that we can't have another 15 years of discussing reforms, my sense is that it's possible at each nursing education institution to actually look at what is possible, within the current regulations. So I think that the regulations and the curriculum are just one important part of what could be possible. So for example, I do think that educators have agency to look at a different way of teaching. Sanele, for example, was suggesting possible partnerships between urban and rural urban and rural facilities. So for example, small things that might ultimately achieve quite a lot. I think this conversation should continue, but I would also urge everyone to actually look at what is it that could be done to move us forward, from what appears to be the current stalemate. What I will do, Lungi, because there were some questions that were asked, for example, how can you encourage students to care when they go into a facility and they find a professional nurse or a unit manager that kind of does exactly the opposite of what they've been taught, you know. So what I will do from my side, you know, if you have all those questions, I'm quite happy to send you like my take on, you know, practical suggestions of what, for example, could be done, you know, in that situation, to just move us beyond this feeling of, you know, that until we have a different nursing, you know, regulator, or until we have a different mode of funding, that, you know, that there's nothing we can do. So my view is that, you know, there's quite a lot. Once we actually start reflecting on what is possible to do, you know, then we will find that there's actually quite a lot that we can do to begin to change the narrative, but also the practical reality of nurses. And I think we owe it to nurses, to nursing, and ourselves to really look at what is it that we can do to make a difference.
Thank you very much, Prof Rispel, even for the effort to sort of answer the questions and provide practical solutions from your perspective about the post questions on the chat box and Facebook. We do appreciate very much. I think we'd move along to Dr. Mkhize. Any final remarks on your side, sir?
Thank you very much, Lungile. My remarks will be that we need to engage, involve, empower. And then in order to succeed in that, we need fiscus. So which means we need to have a budget that will deal with the issues that are affecting nursing directly. And also to say that we also need to be mindful that we cannot work alone. We need to work with other people around us in order to make sure that the social determinants are taken care of, and also to ensure that the young crop that is coming after us is well prepared, is mentored, is given a good direction and supported throughout. There mustn't be the us and them, or an approach that says it was like this in my time, so it can never happen now. Thank you.
Thank you, Dr. Mkhize. Thank you very much for that, sir. We'd move along to Dr. Gwen. Dr. Gwen Lawrence, any final remarks?
Yes, thank you. I just want to start off, I know there will be formal thanks, etc., but I just want to congratulate RHAP and particularly yourself for initiating this conversation, because from the lively discussion we can see on the Q&As and the chats, as well as on the Facebook responses, you know, this is actually an ideal platform and it's long time overdue. So I think it should be the start of many such discussions, and we can bounce ideas off each other, support each other in our individual advocacy efforts, and then also collaborate and forge partnerships that will move us forward. So I also believe, as Prof Rispel was saying, that, you know, you do have that notion of your circle of influence, and there is something like a micro-curriculum, for example, your specific footprint in as an educator. So I obviously accept also the fact that we have to accept new regulations and move forward with them in nursing education, but we can influence it where we are at, and the particular subjects or clinical components that we teach. We can be, you know, we can be that voice into it and putting our own mark on it. So I think, you know, there is possibilities out there, and that, yeah, I would like to see more of these conversations, and that I think it's a good idea that we pick up on some of the questions that have been raised and perhaps have some kind of a formal response to the people that participated today. Thank you.
Thank you, Dr. Gwen. I agree with you there. Sister Lerato, Madumo, any final remarks?
For me, I want to flow from what the guest speaker, Prof Rispel, said in her address, and I want to try and quote her where she speaks about nurses. In fact, she says, they do not have agency. She speaks of nursing. They have power. And then she puts in brackets, even if they do not think so. And they exercise leadership in different spaces. And for me, that sums up these discussions. Nurses are great. Nurses are not just what we want to dub as backbones of the healthcare system. Nurses are the healthcare system in our country, whether we want to believe it or not. And it is for them to then begin to believe, not to be in bracket, to believe that they're indeed powerful. And their power stands in the unity of nurses. And nurses need to begin to unite, especially in the progress of their profession. That cannot be done in the sitting tea rooms when we gossip. We have to start difficult dialogues. We are aware that our profession has always been from the top to bottom. If it says from the above, the nurses are scared. It's a directive from the above. And that notion has really killed our profession. And I think my closing statement, if one needs to really forget about everything that I said today, is the issue of nurses really standing up and owning and swelling their own ranks. I mean, for me, from where I stand, I do not see why, as a nurse who is a facility manager, who is a hospital manager, who is a healthcare leader, whether you're occupying a political, a union, administrative space where you cannot begin to command and be able to care. And because it's a caring profession, even in your management, even in your being in academia, you need to be able to cascade down this care that is in this noble profession. And yes, indeed, nurses are amazing.
Thank you, Sister Lerato. Yes, nurses are indeed amazing, and I guess there's a lot of bias in what I've also said as a nurse myself, but I agree they are amazing. Sister Sanele, Lukhele, any final remarks from your side?
For me, it's just, if as a profession, if we are really to attract the cream of the crop, then there's a few things that we really need to change. It can't be that when we sit and do selections, the students who have the highest APS scores get accepted into other degrees, and then they decide that they're not going to do nursing anymore. We need to work together as a profession to make nursing really a competitor with other occupations, so that we can get good nurses into the field. That is the cry of my heart, that nursing can also have a high APS score, and we don't just get people who do nursing because it's their last option and it's what they could the only thing they could qualify for. So I really think we need to really take our profession seriously and really look at how we can attract, like now, high school students. With the pandemic, we have received a lot of positive publicity as nurses. How do we get those that high school learner who's passionate about nursing to study nursing and not medicine? Like, how do we do that? How do we make the profession attractive? And how do we remove all this red tape for nurses who actually want to climb up the ladder in terms of studying? How do we make it easier for the young nurse? Because the millennial nurse is not going to accept this this constant red tape that is in nursing. So we really have to look at ways to make our profession attractive to young people in order to address staff shortages for the future.
Thank you so much, Sister Sanele, for that. I think that also resonates with the point that nursing is an aging profession. So I think these efforts really need to be fortified. I'd like to hand it over to Mrs. Meghan Bottas just to hear her say before we move on to the vote of thanks. Over to you, Mrs. Meghan.
Hi, Lukhele, and thank you for the opportunity to be a part of this very important discussion. I think that what I'm going to try and do in the next few minutes is just wrap it up and remind us of some of the important points that were made this evening and this afternoon. I think that what's been clear is that in the face of many challenges, it's clear that our country is hungry for transformation and redress, particularly in the healthcare system. And there's been an emphasis that nurses are critical for this transformation to be realized, not only in healthcare settings, but also in response to the social determinants of health. Now, two concepts were highlighted. We have the concept of care balanced with competence. You see, because when we care, we restore dignity to the poor. And that's what our social accountability is about. When we are competent, we improve health outcomes. And both of these result in transformation. We've also been reminded that the poor bear the brunt of any challenge that the country is facing, be it gender-based violence or a pandemic, a health pandemic. So how do we instill in our nurses a desire to see these communities uplifted? So our curriculum must have some ability to instill that desire. Now, our district healthcare system, our primary healthcare system was built on this idea. And so our curriculums, like has been mentioned, should be focused on placing students and teaching them skills for practice within this system. Our re-engineered primary healthcare system is key here. And so our midwife training, and even in our general training, for instance, we don't have the specialist compartment in our training anymore for psychiatric nursing, but we should still be integrating these skills into our curriculum to ensure that the students have these skills for the setting. Then are we collaborating? Are we collaborating with other nursing education institutions and sharing ideas and sharing ways to allow for our students to be placed in community and rural settings? Getting over the logistics of accommodation. Are we sharing the ideas that we have amongst each other? Because I feel like nursing education institutions often work in silos and are more competitive than collaborative. And are our policies ensuring that our best skills, our best nursing skills are focused in these health systems, like our district healthcare system? So just to bring it a little bit back to the topic, in an ambition-focused society, it's very difficult for us to teach the value of extending oneself beyond your own cause and success. And this is where the points of valuing our nurses is important. Because when our nurses feel valued, they will value others. So is our healthcare system really valuing our nurses? This question has been asked financially, not only financially, but in their status, in our scope of practice. Is it being valued? And secondly, is our regulatory body supporting this? Are we feeling supported and valued by our regulatory body? Because when we are feeling valued, we can value others. So just lastly, to bring it back to the last point. In our education system for nursing, is social justice evident not only in our paper-based curriculum, but in our role modeling? So we talk about health system reforms. We talk about how the system needs to change fundamentally. But now for you to take home, something for you to think about, is how high of a priority is social accountability and social justice in your own value system, in your own practice as a nurse, and in your own teaching as an educator? Because it's easier to project a value onto students when you own it yourself. So I think that that's an important thing to start thinking about for us to take this conversation about social accountability in nursing forward. Thank you very much for the opportunity.
Thank you, Meghan. I really appreciate your words, very valuable, especially about the part of owning, the values before you project them to students and in practice in general. Thank you very much. I'd like to hand over this final segment of the program to Mr. Russell Rensburg, just to do a vote of thanks and just final words from his side. Thank you. Mr. Russell?
I was, okay, it's old people problems. I was talking while being mute. Yeah. So firstly, I just want to say thank you very much to the panelists in the first instance who have been very generous with their time and with their thoughts in helping us to start navigating some of these difficult issues around the contestation of our curriculum and the social accountability of the nursing profession and the health system more broadly. Secondly, I want to thank the participants who diligently stayed tuned on both Facebook and on this webinar platform to participate and for the richness of the comments. I think South Africa, what the pandemic has exposed to us is that our system is in need of reform. We talk about the district health system, but a very weakened district health system. Nurses are the front line, but we know that the vacancies are highest at primary healthcare level. We have very difficult situations to navigate. We have a pandemic of substance abuse that's besetting our communities. We have another pandemic or epidemic of gender-based violence, and a lot of those other commercial and structural determinants that's changing our health and our health seeking. As we try and confront COVID, I think the thing that's hardest to come to terms with is that we have over 4 million people living with diabetes, while only 1.5 million of them are currently in care. And that's just generally a primary healthcare level response. And part of it has got to do with the way that we construct health. And I think as we start these conversations around our health system and the reform of the profession, we need to start also adding this conversation of what health is and what health is to you as a healthcare provider and what is health to the communities that seek it. Our communities generally don't trust the health system. Right? We've seen a sharp decline in the amount of people accessing primary health care. And I think we need to start taking a leaf out of what the president's book. We spoke recently about, will we be amongst the gatherers of the new fruits? And I think to be amongst the gatherers of the new fruits, or to be participant in shaping the society that comes out of this COVID epidemic, we need to start cultivating the soil of asking ourselves those internal questions of how we can better serve the communities so that we can realize their potential and release their innate capabilities. But thank you very much for your time, and we look forward to engaging all of you in future webinars. Maybe we'll focus on different things, and maybe our next webinar can look at that. What are the kind of conditions that we need to create to make nursing a profession of choice for our young people? Thank you very much. And thank you, and well done, Lungi.
Thank you. Thank you, everyone, our speakers. I think your points will not go unnoticed at all. And as mentioned before, with the richness in the responses from the questions to the comments in Facebook and here on Zoom, it really does show us that the conversation really needs to continue. So from my side, I'd really like to just extend my gratitude to our panel members, our speakers, our audience. Thank you very much for your support and your willingness to engage in such a very critical topic, as it is also the Year of the Nurse. Thank you very much from my side.
Thank you. Bye-bye.
Bye-bye.
Bye.
Thank you very much. Thank you so much. Goodbye.
Bye.
Bye.
Sure. Adios.